Welcome, everyone, and I'm going to welcome back. I think this is our first meeting since we had our summer break, so it's nice to see lots of people here, and I'm really excited to tell you about Anu, who's been working with me for a little while now, which is a brilliant upcoming star, I'm sure. And so Anu Ramachandiran, a clinical research coordinator and program manager in the Department of Psychiatry at Harvard Medical School and Mass General. She, in her regular 40-hour-a-week job, she oversees a huge multi-site NIH-funded study aimed at improving prediction of mental illness in transition-aged youth by integrating electronic health record data, dimensional symptom measures, and natural language processing. And since that wasn't enough for her, she actually joined my lab as well, where she basically has been looking at the psychological effects of intimate partner violence, and is now leading a study evaluating the effectiveness of a depression screening tool, so the PHQ-2, in IPV-affected individuals. She has a BA in psychology from Stanford and is definitely very passionate about this work that we're talking about here, and more generally about advancing equitable, culturally informed mental health care for underserved populations. And I'm sure she's going to rock it when she is doing her PhD in clinical psychology. And so without further ado, I will let Anu give her presentation.
Thank you so much, Eve, and everyone here. I'm really excited to share a little bit today. Eve has said so much about the really incredible work that all of you are doing and the kinds of conversations that you have in this working group. So I'm excited to be here and talk a little bit about the work that I've been doing in the lab. So as Eve mentioned, we are working on a project that is attempting to validate a brief depression screening instrument in intimate partner violence. So the central question we have is evaluating the diagnostic accuracy of one of the most common brief depression screeners in various clinical settings called the Patient Health Questionnaire 2 to identify moderate to severe depressive symptoms in women who have experienced intimate partner violence. So just some context on what the Patient Health Questionnaire 2 is, or the PHQ-2. So it was designed in the early 2000s following the creation of the PHQ-9 to serve as a rapid triage step prior to the PHQ-9 administration. So it's used as that first initial screening process, wherein if patients then screen positive on the PHQ-2, they're then triaged to receive the full PHQ-9 and then potentially a formal diagnosis by a mental health specialist. So the concept of brief depression screening or mental health screening generally is just to allow that rapid triage, especially in clinical settings like emergency departments, primary care, where maybe analyzing, assessing depression or mental health symptom severity is not the central focus of that clinical visit. It's used as that brief measure, and it provides early identification to improve long-term outcomes. So the first two questions are, over the past 2 weeks, how often have you been bothered by 1, little interest or pleasure in doing things, 2, feeling down, depressed, or hopeless? And patients then respond either verbally through an electronic screen or through pen and paper if they feel that that's happened not at all or nearly every day. And those are coded as 0 to 3 scores. So then after these patients are asked these two questions, if they're then scored a 3 or above on the combination of both items, they're then administered the full PHQ-9, which essentially assesses severity of depressive symptomatology and potentially the need for a referral to a formal mental health clinician. And sometimes even the current treating physician will administer the full PHQ-9 and then will administer what is called the DSM-5 SCID, so the structured clinical interview. So this is just a schematic that was published in the Journal of Cardiac Failure. So this is their formal recommendation for depression screening in clinics that focus on palliative care and cardiovascular disease. So as you can see, they recommend starting with a screener of the PHQ-2, which then funnels into, if symptomatology is present, a formal diagnosis by a clinician. I'm just going to show this very brief clip of what depression screening with the PHQ-2 can look like in a clinical setting that's not mental health specific, primarily to demonstrate why the need for a shorter screener was evolved in the first place. As you'll see in this video, it can become difficult when depressive symptomatology does exist and is prominent in certain groups to administer all 9 questions in an in-person live setting, especially in departments like emergency care. Let me know if you can
Yeah, I'd
hear
like to
this.
ask you a few questions about how you're feeling, if that's all right, and we can try and figure out what's going on. So, would it be fair to say that generally you've had little pleasure or interest in doing things recently?
Yes, you could say that.
How often have you been feeling that way over the last 2 weeks? Would you say several days, more than half the time, or nearly every day for the past 2 weeks?
Almost all the time.
Okay. Would you say you're feeling down, depressed, or hopeless?
Yeah, I guess so.
How often have you been feeling that way over the past 2 weeks? Would you say several days, more than half of the time, or nearly every day for the past 2 weeks?
Yeah. It's a lot.
So more than a week?
Yes.
So thank you for answering all these questions, Mr. Miller. I am a bit concerned about what you've told me, so I'd like to go and speak with a social worker from the team and have her come and chat to you about your feelings. So I'm going to come back once I know when she can come and speak with you and let you know. Is that all right?
Okay.
Okay, well, thank you again.
That's a quick demonstration of what the administration of the PHQ-2 would look like in this setting. The next step would be to get a specialist to administer the full PHQ-9 and or formally administer the SCID for MDD diagnosis. For those that aren't familiar, this is the full PHQ-9. So if those first 2 questions are flagged as positive depression symptomatology, the other 3 to 9 questions would then be administered, many of which involve psychosomatic or physiological symptoms that are often associated with depressive symptomatology. So changes in eating habits, feeling tired, changes in concentration, being more likely to move slowly. And of course, the 9th item measures suicidality. So I won't get into the detail all of this, but essentially this demonstrates all the different types of clinical settings that have formally adopted and recommended the use of the PHQ-2. So the American Academy of Family Physicians, American College of OB and Gyno, American Academy of Pediatrics. So it's also been formally advised to be used in settings where for youth and children. The US Preventative Task Forces came out with their recommendation statement in 2023 on how to screen for depression and suicide risk in various different clinical settings. And they recommend beginning with the PHQ-2 as a triage step. And there's also other recommendations from the Centers of Medicaid and Medicare Services that have also released a memorandum on using certain depression screening tools in adults. There's also, because I primarily work in a lab that works with big EHR studies, I had to include some of these, basically show that retrospectively, the PHQ-2 has been administered over 9 million times for specifically veterans patients who have been seen at VHA hospitals specifically. So this is all retrospective analyses. The PHQ was not administered prospectively as part of a research study. It was just pulled from electronic records that already exist. All these studies demonstrate that every year on a regular basis, millions of Americans are being administered the PHQ-2. So the PHQ-2 was initially validated in the early 2000s when it was developed in general primary care settings. Subsequently, it was validated across different medical settings and smaller clinics. And then recently, meta-analyses have shown that it has relatively high sensitivity and specificity across different clinical settings for the general population. Just to very briefly touch on what diagnostic accuracy tools are used to demonstrate validity of the measure. Most of the tools involve the receiver operating curve, which essentially demonstrates how well a specific screener or measure can perform at determining a specific diagnosis or medical outcome. So a 50% chance would essentially be a random classifier. So something that isn't really doing a great job at evaluating for a diagnosis. A better ROC curve would look like 75%, and a great one would be anything over 90 or 95%. Then also another really important metric of receiver operating curves are sensitivity and specificity. So sensitivity represents how many people truly have the diagnosis or truly have whatever the outcome measure is that the screener correctly identified. Specificity is the opposite. It asks the question, how many people that didn't actually have the diagnosis did the screener do a good job at identifying as not being someone to flag for later evaluation? So, now with that context, here are just a few studies that we found that have recently tried to validate the PHQ-2 in different settings, but have found that there seems to be lower sensitivity of the PHQ-2, so lower predictive ability of this specific depression screener to truly identify cases of people who do have depressive symptomatology. So we can see a meta-analysis from 2007 found that specifically in cardiology clinics, the sensitivity is only about 39%. So the PHQ-2 only correctly identified less than 40% of people who did have DSM diagnosed MDD. Also, specifically in perinatal women, a lot of studies have recently come out that find very low sensitivity during pregnancy, postpartum. In fact, one study found that only 19% of 6-week postpartum women were correctly identified as having depression using the PHQ-2 symptom criteria. There's also been settings in cross-cultural areas. So a study in Peru found that the sensitivity in one primary care clinic was as low as 55%. There's also been studies in other parts of the world, in Qatar, that also found similar sensitivity of the PHQ-2 at its normal threshold, its standard threshold of a score of 3 or greater. So this brought us to question how the PHQ-2 would perform in IPV populations. And unfortunately, we weren't able to find any published studies that were evaluating the diagnostic accuracy of this very common screener in folks who have experienced IPV. This is really critical because, as I'm sure you're all very well aware, that depression, whether it's categorized as an MDD diagnosis or high symptomatology on the PHQ-9, are very prevalent in people who've experienced IPV. In fact, evidence suggests that it's about 3 times a higher rate in women who've experienced IPV versus those who haven't. And there's also literature that demonstrates that this group may be less likely to seek medical care and specifically mental health care. So under detection in a group like this is really important. So our central question was if the PHQ-2 could serve as both an efficient and effective first stage screener in women who've experienced IPV, and how well the PHQ-2 could identify women who would screen positive on the full PHQ-9 if administered. So essentially, women who would demonstrate high, moderate to severe depressive symptomatology. So this is just our hypotheses on why the depression screener and why depression itself may manifest differently in IPV. So again, as I'm sure you're all very familiar with, experiences of IPV and trauma often lead to more psychosomatic, cognitive, physiological symptoms like fatigue, concentration deficits, memory difficulties. They've all been linked to experiences of IPV. We've also looked a little bit at the literature on alexithymia and emotional numbing, which is essentially a struggle to identify with negative or positive psychological experiences. So the concept here is that the 2 items of the PHQ-2 are asking patients to identify, look within themselves and identify if they've been feeling sad, down, or depressed, and or if they are feeling less interested in certain activities, whereas other items of the PHQ-9 ask more general symptomatology about cognitive symptoms and physiological symptoms. So the inability to associate with those with negative depressive symptoms or experiences, feelings may be associated with why we might not see the PHQ-2 performing as well. So that's exactly what we did. We decided to evaluate the accuracy of the PHQ-2 in 2 samples of women, one who have been exposed to physical IPV at some point within their lifetime, and the other who've been exposed specifically within the past 12 months. So our full sample included 223 women, 45% of which demonstrated moderate to severe depressive symptomatology, which is on par with prior research on MDD diagnoses, the rates of those diagnoses in women who've experienced IPV. We also had a smaller sample of women who've experienced the physical IPV in the past 12 months. Those were 82 women, 51% of which ended up having moderate to severe depressive symptomatology. So our outcome here was a PHQ-9 score greater than or equal to 10, which across different research and medical clinical settings has been demonstrated as a reliable, valid standard for identifying moderate to severe depressive symptoms. We utilize that same receiver operating curve diagnostic test that I demonstrated earlier. And the key components of that were the area under the curve, sensitivity, specificity, and general standard error. So these are just some of our results. So for experiences of lifetime IPV, so IPV that occurred at any time during these women's lives, the AUC was relatively high. So the overall discriminatory ability of the test, the overall ability of the test to determine whether or not someone has positive depressive symptomatology was relatively high at 0.87. However, what we think is the most notable feature of this analysis is that the sensitivity was quite low. So the PHQ-2 was only able to identify about less than 60% of women who would have screened positive for the PHQ-9 had they been administered the full test. And the reason why you can see this mismatch between the AUC and the sensitivity is that the specificity of the test, so the ability of the test to identify women who had experienced IPV who did not then meet symptom criteria for depression was high. So it did a really good job at evaluating who didn't have depressive symptoms, but it didn't do a great job of identifying who did. So essentially, 42% of positive PHQ-9 cases were missed using the PHQ-2. As a secondary analysis, we also looked at past year exposure in that group of 82 women. So, of women who have experienced IPV within the past 12 months, we saw similar results at the standard threshold. So, a sensitivity of 55%, meaning that 45% of positive PHQ-9 cases were missed using this initial PHQ-2 screener. And again, the specificity at the standard threshold was very high, which is why we see kind of this higher area under the curve. And also, we can see that the performance is very similar across both groups, but it performs slightly lower in lifetime IPV than past year. These are just some figures that I generated on the ROC curves. Essentially, the closer to the top left corner that an ROC curve is, the better performance, the better overall performance of the measure. So you can see that it's relatively high. So 0.87 has fairly good discriminative ability. But again, the fact that the sensitivity is so low demonstrates that it's really the fact that the test was able to identify the cases that wouldn't meet criteria that's pulling that AUC up. And this is just for our past year group. You can see that the curves look relatively similar. The AUCs and the confidence intervals are about the same. So, what are kind of the implications of this? Essentially, if the women in our sample, these 223 women who have experienced physical IPV at some point in their lives, if they had gone into a clinic and only been administered the PHQ-2, so those first two questions, nearly half of them would not have been then sent on to the PHQ-9, despite the fact that they would have scored positively on the PHQ-9. So this kind of just demonstrates that, had these women walked into an emergency department or a primary care visit, there may be delayed detection of depressive symptomatology. And they wouldn't have been then triaged to the next step of depression screening and then the final stage of a formal diagnosis. So we could be missing cases of depression because of this early stage screener. So potentially we may need to revisit the screening content, but more addressable is that we may just have to provide the full PHQ-9 if providers have some sort of knowledge that their patient has experienced IPV, whether in the past year or throughout their lifetime. So the central question that I introduced at the beginning, can the PHQ-2 serve as both an efficient and an effective first stage screener in women who've experienced IPV? We think that this still remains fairly unclear. Further research does need to evaluate the probability of missed cases of positive depressive symptomatology in this higher risk group. So, the main limitations of our study is that we don't have a clinician confirmed diagnosis. So, even I did submit this paper to a more affective psychological journal. And one of the biggest comments was that we don't have a formal MDD diagnosis as the outcome measure. So, first, I just wanted to show that this is being done with the same methods. There aren't many studies that can have a formal clinician diagnose every participant, especially when studies are trying to validate a mental health screener that isn't particularly in a mental health setting. So a lot of these studies that I'm showing here actually use the same methods that we do. They involve receiver operating curves, and they use the PHQ-9 greater than or equal to 10 threshold as the outcome measure. And again, we're not necessarily trying to demonstrate that the PHQ-2 has low sensitivity for identifying major depressive disorder diagnosis, a DSM diagnosis. We're essentially trying to demonstrate that had these women been administered the full PHQ-9, they would have then been triaged to see a formal clinician who could have provided either an MTD diagnosis or failed to provide them with that diagnosis. Also, we weren't able to stratify by trauma or IPV type or severity of abuse, just given our sample size. So, just to touch on main reviewer feedback and our general plans for resubmission, which will be happening soon. So, when we initially submitted the paper, we actually looked at other combinations of the PHQ-9 that may have performed better in this group, but we've decided to remove those and focus the paper on trying to validate the PHQ-2 itself in this group. Again, like I mentioned, we don't have a gold standard diagnostic interview as an outcome measure, which then raises the question of if symptoms 3 through 9 on the PHQ-9 truly represent depressive symptoms, or if are comorbid with PTSD, or they are kind of more representative of other trauma symptoms that don't reflect depression. But we still think that this work is really important because women experiencing IPV or trauma generally may just manifest depression primarily through these kind of psychosomatic channels. So, pain, fatigue, concentration gaps, sleep issues, just kind of general cognitive and physiological deficits related to trauma. So, this kind of chronic stress and physical injuries as they associate with psychological trouble is important to note. So, it could just be that this is the 3 to 9 symptoms are real clinical presentations of that the PHQ-2 fails to demonstrate. Also, one of the reviewer comments was that we didn't initially look at recency of exposure. So we just kind of looked at the full sample, which raises the question of, does this analysis look different in women who have more recently experienced IPV? So we're now presenting that kind of supplementary past year receiver operating curve analysis, which I showed previously, and both are very similar in terms of AUC sensitivity and specificity. So the fact that the PHQ-2 is missing a lot of positive depressive symptom cases does apply to both past year and fully exposed groups in our sample. Future directions generally for other work would definitely be to incorporate a diagnostic measure of depression, evaluating this in maybe larger, more diverse IPV samples, maybe looking at longitudinal predictive validity of the PHQ-2 and the PHQ-9 scores. And if sample size allows in other studies or in our future work, we would stratify by exposure type and symptom severity. So that's everything. Thank you. Thank you so much. And looking forward to hearing any feedback or questions you might have.
That was fabulous. Thank you, Anu. You did an amazing job. She put that together very quickly when I suddenly sprang it on her that she could present. So it's even more impressive than you would think. So first, I just want to ask, does anyone have questions about anything that was done or comments or thoughts? Angela says it was a great talk. Thank you, Angela. Always very kind. No one else?
I'd be interested in calling on Linda Locke and see her thoughts.
Hi, Linda.
Sorry. I think this is terrific because so I put in the chat that the Edinburgh is still the preferred screener for perinatal people. Problem is it's longer, right? Which is why the recommendation to utilize the PHQ-2 to get to the PHQ-9 so that it's more likely to be used in a variety of settings. And since I do a lot of work with the impact of IPV on health, including mental health, I'm really interested in this research that you're doing. Currently in our state, we're mandated to screen all perinatal people with a screen, and all but one hospital system is using the Edinburgh and the other one is using the PHQ. So I'm going to be really interested in following this because that could have implications on what they're seeing. Just really great. I appreciate it.
Linda,
Since I have-
are you
Yeah.
using the PHQ-9 or the PHQ-2?
So for perinatal people, they're using the PHQ-9. But it doesn't do well either. I mean, that's what some of her research showed, that it's not as good as it could be. And I think there's a lot of really good data on the Edinburgh. So I think one of the reasons that this particular hospital system has chosen to use it is because they feel, well, it correlates with what we're doing in other settings. So if all of our primary care and folks like that are using the PHQ, then what they're getting in the perinatal is going to correlate. So that's their rationale, which is valid. But if it's not it doesn't get the best, then it's still something to be looked at. So I'm really interested in seeing this because I've seen this shift in primary care, particularly to the PHQ-2. And I think a lot of people do that because of all the time limitations in primary care in places other than mental health, there's a lot of pushback in clinics and offices about doing the full PHQ-9. So they just don't feel so comfortable doing it. And the PHQ-2 is more manageable. So this is really wonderful research. I'm so glad you presented it today. Thank you so much.
Thank you, Linda. Yeah.
And so just so I've got a foot in maternal health and a foot in mental health because I'm a social worker and I'm a midwife for 50 years. So that's why I'm doing that kind of comparison information.
That's awesome. Thank you so much, Linda. And Angela, you have your hand raised.
Yeah, I just want to say again, that was a fantastic presentation, extremely clear and easy to follow. I guess one of the things we think about when we're administering tools is how they are administered. And I was just wondering, it's obvious that we think that these tools are administered when the woman is alone. But is that a specification, like the environment? And the other thing people have said over the years, or in some of our focus groups, is people ask, but the way they ask, we don't really think they want to know. So I don't know in terms of the training that goes into do you have any thoughts on the training that goes into administering these tools with respect to the IPV population?
Well, first, Angela, I just want to ask you, when you say your groups of people you're talking about work you've been doing with women who experienced IPV, correct?
Yeah, or
Okay.
have come up in focus groups. Yeah.
Want to clear. Okay. Hey, go ahead, Anu.
Yeah, no, that's a really interesting and important point. I think, honestly, whether for better or worse, it seems a lot more of self-administration, as Linda mentioned in the chat. So oftentimes prior to coming to your primary care visit, you'll get an initial screener to complete before the PCP will see you, and that will have the PHQ-2 in it, and then it
All
will
right.
automatically signal for the PHQ-9 if you score above a threshold of 3, which I guess in one way is a good thing because ideally you're more likely to be alone if you're taking the screener on your phone or on a laptop. But I do think that the PHQ-2 and the PHQ-9 are still regularly administered in clinical settings, and ideally, again, there you'd be in the visit on your own as well without others in the room.
Okay. Thanks so much. And also, while I'm talking, I just wanted to, because, you're training as well, on behalf of Lynn Hawk, she is starting a trainee network the first Monday of the month at 12 noon. And I'm going to put the information on the chat, in the chat.
That'd be great. Thank you.
Yeah, and for the purposes of the data that we had for this study, it was, it was self-administered. So we administered the PHQ-9, and then we just compared how well the PHQ-2 compared to that. Hence part of the weakness, because we don't have a real diagnosis. But yeah, it was, in research too, I think a lot of times it may be self-administered. But I mean, in our case, women were definitely alone. And it's interesting. I've heard different pros and cons over what's better if you ask them or if they do it themselves. Because I mean, it might be easier, like for me to say, yeah, I feel kind of depressed, just like on a piece of paper versus someone asked me. I may be like, no, I'm fine. So there's probably been there's probably been some work on that. I think Linda may have said something about interview is better than self-administration, at least for the people she's working with. But I can totally see it also going another way, unless I've just been already proven wrong by the research. But I personally know my feeling, and I think I would probably prefer to junk. But I don't know. But yeah, I think it's really important that they're not matching up.
I'm a full-time therapist in my real life as opposed to my pink life. And all the platforms that I work on now as a virtual therapist, the client needs to answer those questions. They do the 9 and then the GAD before we see them. And we can turn it on so that every week it asks them or every other week. And then especially the suicidal ideation, if that scores, it'll send us actually an alert. So it's within the last year that the platforms that's like integrated into the software that we use. So I think it's helpful. I wonder though, at time, do the clients then at that point start just like clicking to get through it? But super interesting. I really appreciate your presentation.
Does anyone else have any questions on it or thoughts or ideas? You can even say, I disagree about something. I mean, because we'd rather hear it from you than from reviewers. Yeah. Okay. Well, I'm excited about it, and I know we're gonna get something out there that I think is going to be very helpful to the field. So hopefully that will happen soon. And I think, Catherine, you said you had, well, I know you put an announcement in the chat, but it sounds like yes, there we go. I'll let you take it from there because this was just sent out fresh. I think this is freshly minted, right? The final schedule. They're having trouble with the window. Do you want me to share my screen?
No, I just don't understand why the slide is not, it's normal. Oh, hold on. I have it hidden here. So this is our 2025 virtual conference. It's November 5th and 6th. It is chock full starting at 10 Eastern till 6 p.m. Eastern time. And then the second day, and I'm going to send this out in an email. We do have short breaks for lunch, but not particularly long ones. So if you can take a day off from work and join us for either day or both days, we'd love to have you. It is free. We're happy to do that for a third year and just love to have everybody take part.
Yeah, let me see if I can make it a little bigger. Hold on. That's a little better, right? People can see that now. You can see the different people who are presenting. The nice thing about this is it's not just like, people who have published, you have like talked about this over and over again all the time. We have, new names in here. I mean, not we, and, Catherine is part of this and the Enigma group has really put this together. But it's nice because you can see there's the trainee data blitz, and then there's both practice-based talks and research-based talks. And so it's really a combination of both of those things, which I think benefits everybody because those in research really need to hear more from the practice people and those in practice vice versa. And so that's the first day. And then the second day, it's a similar type thing. And we have Paul Van Donkelaer, who's up in Canada doing great work forever with Karen Mason. And I say Canada is just like killing it. I mean, it's just amazing because Angela and her crew and Lynn Haag and others is just, I'm thinking, the heavens, whoever, that Canada is so strong in this area, given the United States' potentially bad situation. But again, training, data blitz, research, practice, and then more. So it's, and I know, like, I'm pretty sure I know what some of this work is going to be, and it's kind of pretty new stuff. So it's really cool. So if you have the chance, I strongly urge you to try to hop on if you can, because I think it's going to be a really exciting couple of days.
Yeah, and I totally agree. And
It's free. That's the first thing we should have said.
yeah, no, it's definitely free and no travel. And I think the thing last year's comments that we got in the surveys were people didn't take the day off from work and they're like, wow, I wish I could have attended more of it. So you have a month and a half, and it's really worth, if you can get a day off, to be in that space, because I do think, like Eve so all said, it's measured in different sections, and specifically so that if you're there a day, you get a bit of everything. Yeah, and I also have to say, great work in Canada, and I am impressed how the Canadian government, keeps supporting with grants and stuff. So we may all have to go to Canada eventually.
Yeah, no, it's brilliant, brilliant up there. And the other thing is, if you have something that you have an interesting new thing, either some clinical thing or research, and you might want to present it, if you go to this conference, you could potentially be presenting it at next year's conference, because it'll probably come back next year. So it's also another way to sort of get exposure to something you might be able to be a part of in the upcoming years. So, yeah. And I don't know if there's any other. Oh, do we know enough about IBIA or whatever next year to say anything, Catherine?
NABIS, which is North
DC.
American Brain, will be in DC in March. And then in 2 years, we'll have IBIA. Sorry.
That's right. NABIS. Yeah. I always get them confused. It's like natives, but yeah. So if you're interested in more brain injury stuff, NABIS in DC in March, then IBIA will be back again.
And we will have a meeting of this group in person one of the days at that DC meeting, to be announced.
Oh.
So, and does anybody have any other announcements? Emily put in the chat, new resource available to share. Looks like it's going to be published tomorrow, but it's not embargoed. So
It's currently up. For some reason, it says will be published tomorrow, but I sent it to Rachel Ramirez from ODVN, and it's the project that she and I think other folks in this group were working on. And so you're cited in it if you were one of the folks on there. I think I saw your name, Dr. Valera. Thanks for sharing. But it's like an intro thing for folks who are like kind of just getting a taste of things. So
Awesome. Thank you for sharing that. And yeah, I don't know if this has anything related to it, but with the new NIH rules, things are, it's kind of unfolding now, but you're technically not really supposed to be able to embargo any publication anymore. So if your work was funded by NIH, usually the journal would be like, okay, you can't, for a year, unless you pay to have it open access, no one can see it unless you have a subscription. And NIH basically said, no, if you've been using our funds, it's going to be available immediately. So I wonder if that has something to do with that. But that is something for any of you researchers out there to be aware of, because it's creating some problems for some people who are like, now what do we do? Because the journals are like, well, yeah, you're supposed to pay now if you have to open it. So it's just to put that on your radar as something to be aware of going forward. If you're not getting funded by NIH, it's probably irrelevant, but if you are, it may very well affect you. So, sorry about that. Good Lord, that was loud.
anyone else like any announcements from their state, their country, anything that they'd like to add?
Quiet group.
All right. Well, I
We're
appreciate
still sleeping from the summer. There's summer slumber.
We'll have a meeting next month in October, and then we'll have the conference instead of a meeting in November. So thank you, Eve. Thank you, Anu, and appreciate everybody's time. Anything else you want to say, Eve?
Yeah, I think that's it. Thanks everybody for coming. Appreciate it. It's good to see a lot of familiar names. Happy to see you, and hopefully y'all learned a bunch, or at least a little bit. And thank you so much, Anu. I literally invited her to do this like last week, and she was a trooper and put it all together. It was amazing. So super huge props. Thank you.
And congratulations to Phil Butler for getting her doctoral. Very impressed.
All right.
Yay, Phil. Awesome. So again, this hope our group nurtures everyone along their journey, and we'll see you all next month.
Yeah. Yeah.